Dr. Chen, will everyone eventually get this virus?
Eventually, probably, if this becomes a seasonal infection, which means that once we get over this season, it becomes one of the many different respiratory viruses that we can encounter every wintertime predictably, then yes, maybe over your lifetime of however many years you have left in your life, over 50 years, you may encounter this infection. Now, whether or not you will encounter it before we have an effective vaccine or some of the therapies that we're right now trying to test and evaluate for efficacy, you know, again, a lot of the scenarios show that a significant part of the population at large will probably be exposed to and have the infection. Now, gladly, what we're seeing is that there are asymptomatic infections and mildly symptomatic infections. So, you know, again, it's not necessarily for every individual the end of the world to get the infection. But we want to raise awareness that there are high-risk parts of the population. And again, all of us have grandparents or other older adults that we interact with routinely. And so there might be others that are immunocompromised around in your communities or, you know, your friends and loved ones. And so, again, we want to be mindful of those people as well that could encounter the infection and have severe disease.
Great. Thank you. That's good to know. And you'll find there's a lot of overlap in these questions, Dr. Chen, because there's so many interconnected parts to this. I'm trying to organize them in a way that will make sense, and you answered a fair number of them in the beginning of with your remarks.
Okay.
A couple of people have asked, are there two strains of COVID-19 virus? And if so, is there a test to detect which one, and is one worse than the other?
Yeah, so that's a good question. People are asking basically, is this virus kind of changing? Is it drifting in any way since it first emerged? And a lot of sequencing have been done of the various different viruses that have been isolated all throughout the globe and compared to the kind of the original viruses. And we're not finding significant changes. There are very minor changes, but not major changes. We're not seeing that there are, you know, 2 or 3 different what we call clades that are causing different types of disease. So so we're hoping that when we land on, and I'm saying when, it's just a matter of timing, land on making a vaccine, that vaccine will protect against all of the circulating COVID-19 that we're seeing globally right now.
Great. So it's not exactly at this point, as far as we can tell, like the flu, where, you know, the vaccine changes every year as the disease itself morphs. Is that it?
That's right. Yep.
Okay. Great. Thank you. Let's see. So you talked about possibly having to quarantine again, or maybe we're going to have these, you know, these peaks and valleys and whatnot. So is there yet a test? Well, we're talking about, will we need to quarantine? Yes. So here's one. I just had a baby. How worried should I be about family possibly being asymptomatic, but being around her?
Yeah, this is a tough one. And we've actually had some of our hospitalized patients be pregnant women that have had to deliver early, and we've been watching their babies as well. So, you know, I understand the sensitivity. I think at this time, what I would advise is that you make a virtual cocoon around the baby, which means that you, I know that you have loved ones, family members that want to come and visit the baby and help out, but try to limit that as much as possible, because I think you're right. At this time, we don't know if how much asymptomatic infection there is out in the community. But again, if these family members are coming from afar or even in the next county, I just don't want to risk having them bring in the infection and infecting the child. And even though the majority of infections among very young children are mild, babies are you know, relatively vulnerable. They're immunocompromised to the extent that they're not mature in their immune systems as well as, being a baby. So they're not mature in developmental stages as well, as far as their lung function and other things. And so I think at this time, I would practice the utmost caution. And that's why building a virtual cocoon, which means that you kind of limit the people that are coming in close contact with the child.
Great, thank you, Dr. Chen. So I'm going to move on to these questions about prevention. We'll start there and move on into testing, treatment, and vaccine. So the prevention questions are all fairly similar. I'm just going to sort of run through a few of them, and then perhaps you could construct a response that might hit the points that are mentioned. One person asked that we are assuming that masks, hand washing, and social distancing reduce the risk of transmission and acquisition. And you don't have to answer this, but it says, is there epidemiological based data to support this? And I think the data that you shared at the beginning pretty much captures that. So the questions then go on to, is there value in wearing masks and gloves in public? If family members have been quarantining diligently for 5 weeks, would it be possible to get together with each other? And if not, how long should we wait? Should we wear masks and gloves?
Yeah.
Then someone said, if you can't get an N95 mask and you're considered high risk, is there any suggestions other than hand sanitizer, bandana, or scarf to protect yourself when you have to go out? And then, how can we safely get groceries? Will a product on a grocery store shelf that has been touched by someone that has COVID-19, will that endanger me? And I think that's pretty much the broad range. I'll let you sort of answer the prevention questions as best you can.
Yeah, let me see how I can address all of this, because I started losing the thread. But so I think one of the concepts is what questions about masking. Who does it protect, really? So when we talk about healthcare workers, those are the ones that are exposed throughout their routines within the hospital and taking care of patients to people who have COVID infection and could generate short distance aerosols because they're either infected and coughing on a ventilator or having to be intubated or getting suctioning. All of these are kind of procedures that can cause what's called short distance aerosols, which means that, again, they're very fine in size, but they only go short distances. It's not like an airborne, which stays in the air for long periods of time. So it's a short distance aerosol, but it again requires that healthcare workers wear an N95 mask and honestly a face shield to protect their eyes, nose, and other mucous membranes that are not necessarily, especially the eyes, that are not covered by the N95 mask. So that's for healthcare workers, but for the rest of us folks that are not in the healthcare setting, the reason why we're encouraged to wear masks out in public is because, again, we ourselves at any moment may be an asymptomatic infected person, and so by virtue of wearing a mask, we're covering our ability to when we talk to one another, be able to transmit the infection. We're also trying to, as a society, kind of sensitize everybody to the normality of wearing masks. So that's actually another kind of reason for us to wear masks across the board. In Asia, it's very common to wear masks in public, but here in the US, early on in the epidemic, when Asians wore masks in the American public, they were shunned or they were spit upon or called curse words or other things. So it was not well accepted. So we're trying to acculturate all of us to how normal it is to wear masks out and about, but it's also a measure to, again, prevent us from inadvertently transmitting from one another. Now, most of us are not infected. So really what it is it's preventing us from transmitting to another person inadvertently if we happen to be infected. The mask is not protecting you. If a person is infected and you're wearing the mask, doesn't protect you because they can still cough or sneeze on your face and go into your mucous membranes, which includes your eyes. Or you could touch a surface and rub your eyes or face or something like that. So again, masks are important when we're out in public because we're trying to set the standard for how normal it is to wear that in public. And also, just in case if we're an asymptomatic infection that we don't spread it to others. So the other part of that is of course, that we want to continue to practice hand hygiene, hand sanitization, washing our hands, and not touching our faces. Because again, that's another way that you can get the infection. Going to the grocery store, again, we're wearing our mask. We're not touching our face as we're shopping. We're trying to make our shopping trips as efficient as possible. So I always try to tell my wife and my family members to write a list so that I know exactly what I need to get and I know where to go, and I'm just going straight to the aisle, picking out those items, not trying to browse too long and getting out and trying to limit my kind of physical distance among others as much as possible. So when we pick our groceries, again, yes, others might have touched it. So when you go home, you may want to wipe down those common items. So for boxed items, you may want to wipe it down. You could spray it with a bleach solution and then wipe it with a cloth. For our vegetables and fruits, you want to wash the exterior. Again, you know, those are kind of some of the things. For those who are, I heard part of the question was a person who is immunocompromised themselves, should they wear an N95? And so, no, that's not it, but they do want to limit their interaction with others. Again, if another person is ill and has the infection, they're worried about trying to limit their interactions of getting the infection.
Is it possible to get treated for or get tested for COVID if you have few or no symptoms, if you are an essential employee?
So that is the vision for the future, for the hopefully in about a month or two. As we start, and this is kind of conversations with Governor Hogan as well, is as we start entertaining the ability to open up and you know, relaxing some of our physical distancing measures, as we maybe then start opening up certain businesses, someday opening up schools, you know, that what needs to be in place for us to be able to do that? One of them is that we have to have the ability to do lab testing. And so, yes, we want to be able to do testing on people who are mildly symptomatic as well as very symptomatic, which is what it's really limited to right now. Those people who are very, very much symptomatic, not mildly symptomatic. But and then we'd also like to be able to do contact tracing, which means that if you are in contact with a person, even who is mildly symptomatic but proven to be lab confirmed, then we would like to open up the ability to wide-scale lab testing for all the people that a person might have been in contact. So yes, I think essential employees would be certainly covered under that situation.
But that sounds like it's a little bit further off in the future.
It would be maybe in a month or two. Okay. We're, again, almost on a daily or weekly basis, we're trying to review our ability to ramp up and do lab testing across.
Great. And in fact, that's a question a lot of people ask, which is, where are we with testing? Why is it still so difficult to get a test? And is there something about the tests themselves that are problematic?
Yeah, good question. So it's not necessarily the test itself, but there's all sorts of things that go around the test. So one of the things is that for the PCR-based test, which is when you take a respiratory sample, that respiratory sample has to be obtained by a special swab, not just a common Q-tip. And then there are other swabs that are, you know, have the wooden handle. This has to be a special, what's called flocked swab that's made with polyester or other kind of synthetic fibers. Because the wooden swab and some of these other types of cotton swabs actually have small inhibitors in it because of these natural fibers that actually prevent our ability to have a good test. So these special flocked swabs are actually in very short supply all nationwide. And we're running out of them, and we actually have very few of them. There's also something called viral transport media that those swabs have to be put into once you've put it up the nose of someone and you have the swab, put it into a tube. That viral transport media also is a precious resource. Now, laboratories are able to make that. The recipe is actually very common, so we're able to do that. So that's not as much of a limitation, but that's been part of the discussion. Then you have the actual assay itself, which there are a lot of different companies that make their kits, and each company has a proprietary kit. So if you run out of that kit, you can't use that test for that platform. So we have actually in our hospital system multiple different platforms. So we have an Abbott, we have a this or that, we have another one, so that we have maybe 50 test kits for this one before we run out, but we have 100 of this one, we have 200 of this one. So collectively, we are able to do more testing. Again, we are fortunate enough that our campus has the IGS, and they have really stepped up to the plate and really grown an in-house test so that they can ramp up to perform anywhere between 10 and 20,000 tests. I think it's per day, or maybe it's per week.
Wow.
But anyways, it's some amazing capacity that they're rapidly building up toward. So that's why on a daily basis almost that we're seeing differences in our ability to do lab testing. But a lot of it has been because of resource that are limited on many different levels.
When we talk about the proprietary kit, I'm just going to interject one of my own questions, my only one, I swear. Are these same problems the same problems that other countries are experiencing? Or does the assay itself and being proprietary, is that specific to maybe say more capitalistic countries, or is it the same everywhere?
No, I think it's the same everywhere.
Okay.
These are companies that are international companies, and they can only supply so much all around the world. So there's an allocation and a resource.
Got it.
And on top of that, you might have heard, how even for mechanical ventilation, states are competing against each other to try to get, to order mechanical vents. Countries are competing against each other to try to outbid each other. It's kind of gotten to this, this level where, again, if you have precious resources, a person who's thinking, about money or about a business can charge much more. We're seeing that with, hand sanitizers on eBay and Amazon. So again, that speaks to kind of the level of resource limitations we have globally.
Yep. All right. So I'd like to move on to another topic area. And just to let everyone on the call know, we are planning to put the text as well as Dr. Chen's slides, the questions and answers, and possibly add answers to some of the questions we're not able to get to live today. So look for that on the UMB website, either on the Center for Global Education or the COVID-19 page. Let's talk about immunity. So are we preventing or disrupting herd immunity by isolating and overprotecting ourselves? What about those people that say we should just get out there, expose ourselves? Yeah, a little percentage of us might die, but the vast majority may either be asymptomatic, have some symptoms, go through it, come out okay on the end. What would you say about that? Are we disrupting the ability for us to have herd immunity prior to a vaccine?
Yeah. Well, so the other part of the equation, though, is whenever we hit a peak of infection through a community, a certain portion will have serious disease, require hospitalization, and mechanical ventilation. And if you allow that population to go through it and just get it done with all at once, you will overwhelm the healthcare system locally, such that, again, what we're going to see is chaos within a few weeks or just a few days, where we're going to have people turned away from hospitals and people dying in the streets. What we're doing with these interventions and trying to delay and flatten the curve, the flattening the curve, of course, kind of is self-explanatory, where we're trying to minimize the number of people who are hospitalized and on mechanical ventilation. But what the delaying of the curve does is right now, or over the past couple of months, and right now we're continuing to surge, is trying to build out our ability within the medical systems all across the US and in our state as well, to have more hospital beds and mechanical ventilation that will be available. So you heard probably about the Baltimore Convention Center being turned into a massive hospital where we have beds being put up. These are kind of rudimentary ICUs and hospital beds that we can take care of people. If we didn't have enough time to set that up, then we wouldn't be able to handle that. We're turning, you may have heard about the Lord Baltimore and other hotels into hospitals. We are taking old hospitals that were decommissioned and empty and refurbishing them and bringing them back online as hospitals. And one of the ones is, I think it's Laurel Hospital in PG County. We're doing a number of things. We're trying to create this surge capacity, and this takes time. And that's what delaying the curve does, is it allows us to have that surge capacity. We do not want to get to the point where, as a society, we're watching people dying in the streets because there simply are no hospitals and not enough mechanical ventilation. Now, it may come to that, but we're trying to minimize that impact.
Yep. All right. Well, that makes sense. So then there's some questions about people that may have post-infection immunity. So what research studies are being undertaken, as you know, from what you're aware of, to assess continuing immune responses of previously infected individuals? And when do you think the first information might be available about post-infection immunity?
Yeah, very good question. I think all the academic centers across the US are probably trying individually to do this. In fact, I got emails from my NIH colleagues and even FDA colleagues that the FDA colleagues are trying to help to understand so that they can try to have tests available for convalescent sera or convalescent plasma as a therapeutic measure. But part of that is looking for immunity. What are the neutralizing antibodies? What are the levels that we need to see in plasma? The NIH folks are also trying to develop therapeutics and vaccines and trying to understand immunity as well. We here at the CVD are putting together a sero survey so that we can basically use an antibody-based test to do serologic prevalence testing in our communities or even in healthcare workers and everywhere else on campus and about, and to understand how much of the population has actually experienced the infection, basically by looking at the antibody responses in the population to see who has high and who has low antibodies, implying basically the people with high antibodies have been exposed, whether or not they had symptoms or not. Again, all of this is building toward trying to understand the immune response. And eventually, and I don't know when we'll have the data, is we'll be able to know by some of the either antibody tests or other cell-based tests or something else, who is actually immune to reinfection and who is susceptible. That would be great. We're working toward the CVD, but other groups are as well. I don't know who's going to scoop who. I would love to be able to publish this, but we're still trying to get the assay up and running right now.
Okay, great. So do we know if reinfection is possible? Can the virus after initial infection become dormant and then reactivate later? Do we know that yet?
Yeah, so that's also something that we're trying to definitively understand. We're hoping that this is the case. We're not sure. It might be very short-lived. So it could be that you get the infection now, but then it doesn't protect you in about 6 months. So you may get reinfected come the fall.
So stay tuned.
Infection now, and maybe you get reinfection in, re-exposed in a month, and you could get reinfected, but maybe you have milder symptoms. That could be a scenario. So it's really unknown right now.
Lots of information pouring in, I know. Let's ask a couple of questions about treatment and vaccine. So right now, Dr. Chen, do you know, are there promising clinical trials for treatments to help mitigate some of the more serious ramifications of this?
Yeah. So the most advanced therapeutic trial that I know of is the remdesivir trial, which is an antiviral, which is kind of the leading one. And we are one of the study sites globally. There are 50 or 60 sites that are involved. And we just surpassed 800 enrolled participants just yesterday, which means that we've actually reached the target and we can start doing our interim analysis now. So we'll know within the next week or two whether or not we have documentable efficacy with remdesivir, which is the leading antiviral. There are other antivirals that are being evaluated. There are also other immune modulating kind of therapies that are hopefully going to decrease the severity of disease, and those are at various stages. Chloroquine is also being evaluated. A lot of people are using it because it's FDA approved, and there's really no evidence. We don't know if it works. We know that there are significant toxicities associated with it as well that are under-recognized, but so many people have been talking about it that people are kind of using it as standard of care within their own hospitals, even though there's no evidence that it is efficacious. And in fact, without randomized controlled trials, it could be that there is actually more harm than good with chloroquine. So again, that's another trial that we're waiting for good standardized clinical trial results to show that. And then
Do we know, are those ongoing, do you know?
Those are ongoing. So
yeah.
I don't know the status of a lot of those.
Okay, all right. So there's a question of treatment, like what can we do now in the absence of a vaccine, right? And it's great to know that UMB is involved in that. But the vaccine is sort of the focus of a lot of the questions we received. And, easy questions, Dr. Chen. I'll start with this softball. When do you expect the COVID-19 vaccine to be ready for public use?
Yeah. So that question implied that there's a single vaccine. And so I think one of the concepts is that we want to have multiple different vaccines being evaluated simultaneously, because any one vaccine can fail at any time during the clinical trial. So there are a series of clinical trials that need to be conducted, even though they're being done at increasing speed compared to traditional speeds of doing clinical trials. But these vaccines may fail because they may actually be associated with more reactions than we can tolerate, or maybe the immune response just really isn't sufficient enough to provide enough protection for the individual. So again, we want to have multiple different vaccines, but the bottom line is we have multiple vaccines that are being evaluated. The Moderna vaccine is being evaluated, was the first off the block. That was started in mid-March. That's being evaluated by one of our sister institutions in Seattle through the Vaccine and Treatment Evaluation Network. And then there are other vaccines that are being developed right now. And so, here at the CVD, we're fielding almost on a daily basis different organizations, manufacturers that want to test their vaccines. And this is a good thing. We want to have multiple different vaccine candidates being tested. And if we have multiple different vaccines in about a year's time that are licensed and approved, great. That would be a great situation. I think, again, I'm saying in about 12 months, we'll see some vaccines that are successful, and that will be at the point where they can be licensed. Now, that means that at the point for licensure, a year from now does not mean that it's immediately deployable to a population. So again, you're thinking about multiple different manufacturers, multiple different vaccines. hopefully getting licensed around a year from now and slowly being deployed to the global population. But if there are multiple different vaccines and manufacturers simultaneously, then that will allow us to deploy them more quickly.
That's good to know. Have we seen any outcomes from any of these yet, or is it too soon?
No, too soon.
Okay, that's what I thought. Let's see. My goodness. Let's talk about the future. Put on your prognosticator hat.
Sure.
I recognize it's 12:47, so we won't get to all these questions, but if people have questions, feel free to type them in the chat, because I'll get a transcript of that and we can add those to those questions we answer. There's a question about mosquitoes. With summer approaching, is there a thought that mosquitoes could also carry the virus person to person?
No, we actually feel pretty confident that mosquitoes will not be a way to transmit the infection. If you look at the American Association for Blood Banks, they actually have a statement about the lack of any evidence that through blood that the virus is transmissible. So we really think that it's isolated to respiratory.
Okay, that's good. So do you have, there's a lot of questions about, and I think I'm going to save these and we can get UMB leadership on them, but the question about what sorts of risk assessment considerations we should be thinking about in terms of reopening. And there's a lot of questions about the reopening, but due to time constraints, I'm going to skip those today because I think we're quite a ways from that. And perhaps we can have you back again when we get a little further down the road with this. So the question is, what is the best advice that experts like you could give today to the state, city, and perhaps federal governments? And what should people like us, just normal citizens at UMB, be doing in terms of any advocacy that you might feel would be appropriate in terms of where's the push point? Is it the testing? Is it the vaccine? Is it what are the things that we should be focusing on?
Yeah, for all of the listeners, you know, I guess the biggest thing is to continue to understand the importance of this physical distancing. Hopefully a lot of you have adapted to the telework approach and hopefully are becoming more efficient in your work. Even though you're doing it outside of the office environment or the classroom environment. You know, we want to be able to share kind of our success stories. There may be certain things that some people are doing that have been highly successful that we can adapt ourselves. You know, in my family, one of my daughters is learned how to sew with the sewing machine. My wife taught her over the Easter weekend, and she started making some masks. So she made this mask for me. She made
that is awesome.
And so you know, so maybe some of you are crafty and want to start making masks. So again, as we start opening up the campus, you know, or businesses or everything else, that you know, cloth masks are going to be an important part of us, you know, just kind of being normal when we're out and about. And so being prepared for that, maybe making some for your neighbors or your, you know, friends, other staff or faculty members. So that could be something. I think you've heard about, you know, other local businesses like small restaurants and things that are certainly having a difficult time. And so my family has also been trying to, we don't go out to eat a lot, but we have been trying at least twice a week to order out, you know, carry out, of course, DoorDash and whatever else, Uber Eats. So that's just trying to be mindful that there are certainly other people in our communities that are affected. And I feel blessed because, you know, I've got a great job here and I don't have to worry. But I know that daily there are people who are either homeless or other populations that that are under duress, and so are not able to cope under this situation. So I don't know if there are kind of grassroots efforts to put our heads together collectively to help out those communities as well. We know that there are certainly those members close to us, whether we know it or not.
That's a terrific segue to the question that several people asked, which is, how do you think we can prevent the disproportionate number of affected people of color during COVID-19?
Yeah, and this is another thing that is unfortunately, this COVID-19 situation is just unveiling, you know, a lot of racial disparities and just disparities of healthcare and disparities in socioeconomics, locally here in Baltimore, but all throughout the U.S. as well. Is that you know, we're seeing right now the burden of disease for severe disease to be among African Americans in many of our communities. And again, these are the communities that have more prevalence for chronic medical conditions that are the ones that are associated with severe disease. So it's not that COVID-19 infects Black Americans more often, but it's just that because segments of the population have more hypertension, diabetes, obesity, or other factors that, again, are known to be risk factors for severe disease, that's where we're seeing this disparity in hospitalizations and deaths in our population. And so, again, it's one of these things where, you know, we want to be cognizant of equity.
Yes, exactly. So as we begin sort of the wrap up of this, I think there was a question, and I see that one of the students probably asked the question in writing and is with us, was asking about how contact tracing is going within the state of Maryland. And I don't know if you know this or not, Dr. Chen, but is there a potential role for medical or other health professionals or students to get involved with that? I think particularly from the student side of things, in fact, the query I think came from a student. Is there a role for students to get involved with the contact tracing, and what do you know about that? Or
yeah,
if you don't know anything, that's great too. We can try to get to work on that.
Right. Well, so this is a discussion with Larry Hogan over the past calls, and so we're basically a lot of the discussions have been around. If we want to have a scenario where we're relaxing our non-pharmaceutical interventions and opening up our physical distancing and opening up businesses and everything else, you have to have lab testing and you have to have the ability to do really good contact tracing. So a lot of the local and state public health authorities have been trying to increase their capacities to do contact tracing. What we've been talking about is actually enlisting some of the local health providers, so the local clinics, medical clinics, or even dental clinics, where we have, you know, professionals, medical professionals who could be trained very quickly to be able to be repurposed during their downtime to be able to do contact tracing. Now, for medical students and other students across our campus, all of the professional students, there may be opportunities. We haven't talked about that. We've been mainly talking about opportunities open to those who are already licensed. But again, there may be, I would encourage people to just keep their eyes open for those types of opportunities that might be available. I think you've seen that there have been pleas where medical students can actually enlist in the Maryland response team, which is managed by the Maryland kind of public health. And you can go into the website and enlist as a volunteer and do a number of things. You can be in a call-in center as a hotline recipient and go through questions for call-ins. You can be at a PPE donation site where you're receiving PPE that's being donated by community members. So there are a lot of pleas that I've been receiving over the past few days for that. There are also volunteers for some of the temporary hospitals that we're standing up as well. So there may be opportunities there as well through the Maryland response.
That's a great suggestion. Thank you. I saw that that was up and running. And to sort of wrap up and be respectful of people's time, my favorite question was a question that was addressed to you, Dr. Chen. Specifically, how are you keeping healthy during this time?
Well, you know, I'm actually doing pretty well. You know, I work like crazy during my office hours, but I have a long commute going home, and so that allows me to decompress and get things off my mind. And when I get home, I essentially try to put as much work away as possible and spend time with my family members and have a nice dinner. And I even get on my treadmill and try to make sure that I'm routinely keeping up with my own exercise. So I'm trying to take care of myself. I'm also trying to make sure that I get, you know, about 7 hours of sleep, a lot of sleep, you know, so I'm getting restful sleep. I'm trying to keep up with my, you know, healthy routines, you know, wearing a mask out in public, as you saw, you know, my daughter's mask that she made for me. And since I'm the one who's out of the house, I'm doing the groceries. I have a grocery list that I, you know, try to get all of it done all at once, once a week. And then I wash my hands as soon as I get home. And my wife kind of wipes down the groceries and those sorts of things. So that's in our routine as well. Again, my family members are staying sheltered in home, you know, practicing that physical distancing that we're all preaching.
Thank you again, Dr. Chen. Any final words?
From me?
Yeah.
Everybody stay safe. And
there you go.
Have a positive perspective. You know, I think it's been difficult for everyone, but I think that, again, we can have a positive perspective, and you know, we're all working together toward the same goal.